I'd like to introduce to you the President of the University of Maryland, Baltimore, Dr. Perman. University of Maryland, professional and graduate university comprising schools of medicine, law, dentistry, pharmacy, nursing, social work, along with an interdisciplinary graduate school. Dr. Perman is a pediatric gastroenterologist, and he actually still practices medicine in his Weekly's President's Clinic, where he teaches team-based care to students in all 7 schools. So with a round of applause, let's welcome Dr.
Brian, thank you so much. It's just a real privilege to be here, and I have to thank all of you for coming out tonight to spend some time with us. It's probably not appropriate for me to say this because of the gravity of the topic, but for me it's a personal joy to be here, and I'll tell you why. It's allowed me to reacquaint with a number of colleagues who are in the audience among you. You know who you are, who have been very meaningful to me over my many years in this area, so that's a treat. I have current colleagues here with me from various of our schools, and I've met some alums who I haven't had the privilege of knowing before this, so I really appreciate our opportunity to be here. You all know that we tried this once before, Brian. The weather didn't cooperate, so I'm glad we have collectively a chance at a do-over. Brian, your hospitality, that of your staff, I said to you, you may be a businessman, but you're also a great public servant in doing things like this. I know there's some folks here from the County Executive's Office, from the Anne Arundel County Health Department, the Anne Arundel Medical Center. Again, it's our privilege to join you. And I know, as Brian said, that the topic we've come to discuss is a difficult one. Opioid addiction is painful. It robs us all of too many people that we love, and it leaves a great deal of wreckage in its wake. And it's precisely because of these sensitivities that I do want to mention up front, so that you all know we're taping this event. You know, it's been a year since Governor Hogan declared a state of emergency in Maryland for our collective opioid crisis. It is a crisis. You probably know these data better than I do. In the first 3 quarters of last year, Maryland had 1,500 opioid-related overdose deaths, which comes out to about 4 people a day. And that death toll is nearly double what was experienced here in Maryland just 2 years earlier. And any respite that we've had from the leveling off of heroin and prescription opioid deaths has been wiped out by synthetic drugs like fentanyl and carfentanil, which account for nearly 80% of Maryland's fatal opioid overdoses. And as painful as these statistics are, because every single one of those numbers represents a life lost, I think we might all agree that addiction itself, the toll it takes not only on the person who is struggling, but his or her loved ones, it's often like a death itself. Death of normalcy, of hope, of peace. It's a life lived in constant fear. And I will tell you, my life has been touched by this crisis. I think some of our panelists might say the same. And if you're comfortable, I'd like a show of hands if you know of someone who struggled with addiction, who's struggling still. Yeah. Just what we each would expect in talking to each other. We need to see each other in order to see the crisis for what it is. It's very pervasive. Doesn't matter who you are. It's very indiscriminate. And I think in acknowledging that to each other and raising our hands together, we also recognize that we're not going to get anywhere if we don't erase the stigma associated with addiction. You'll hear Dr. Coop say that he doesn't even use the word addiction.
Yeah.
He refers only to its mechanisms, reinforcement, dependence. And that reminds me to tell you that we recognize at the university that as part of a comprehensive research program, and that's so much of what we've come to talk to you about, how are we going to get ahead of this? We have to look at the likelihood, and I'm sure many of you have thought of this long before I did as a kid's stomach doctor. We need to recognize that there's likely a genetic basis to addiction. You know, not everybody who takes painkillers, even for extensive periods of time, gets addicted. Why is it that certain folks get hooked on painkillers? We need to understand the molecular basis. And if we can do that, then you obviously see the opportunities for managing patients with regard to their need for pain relief, which is important, in a very personalized way. We also realize in our collective work that we have to look at pharmacologic solutions, which we will be discussing today. And we certainly, no matter how good we get at prevention, we need to look at treatment and support through the process of recovery. We have to look at mental and behavioral health resources to accomplish that work. We certainly need to look at prescriber rates and what a place like ours that's responsible for producing the majority of the healthcare workforce for this state, we need to look at how we might better educate providers. And I know that Brian's leadership Anne Arundel class is focusing on this very issue. We need to look at local, state, national policy. We're fortunate at the university that we have a law school and we have a social work school whose dean is here with us tonight that can help us in those regards. In other words, we have to put everything, every aspect of this complex problem, as Brian called it, on the table. And we're obviously ready to do that. The state has made some headway already. For example, opening access to naloxone, testing a Medicaid waiver for residential treatment programs, and obviously launching some very effective awareness campaigns. Anne Arundel County, I know, is a leader in this space. It's doing a lot of smart work. The Safe Stations program that I've learned about in preparing for tonight goes a long way toward destigmatizing addiction and providing residents a low-risk way to get help. And this county's peer-based recovery system uses good evidence on addiction and recovery behavior. So I think that this epidemic that we're all here to talk about has brought us together around one core truth, and that's that our solutions to a complex problem have to be multifaceted. That education alone, or treatment alone, or prevention alone is necessary, but insufficient. And that's why we're here. You know, we have the name Baltimore in the title of our university. But we're here and elsewhere in the state because we have a statewide mission. We have a statewide responsibility to Marylanders. You all help us with our mission through your taxes. We don't forget that for a minute. So we're very focused on the needs of Baltimore, but we never forget our responsibilities to the state, and we're happy to have a chance to come out to this part of the state and meet with you and sort of tell you what we're doing is our way to be accountable to you. So it's more than time. I've said more than enough. It's more than time that we get into it. Our first speaker, I alluded to a few moments ago, and I know he has some alums here. Welcome. Is Dr. Richard Barth, who's Dean of the University of Maryland School of Social Work. My colleague here has for decades been a leading national scholar on child welfare services and parenting. But as such, he co-authored the book, Families Living with Drugs and HIV, which was a response to the crack cocaine and HIV epidemic of the 90s. Dean Barth has subsequently consulted with leading research groups on how to help people in recovery be parents successfully. He's a leading scholar on evidence-based human services practices, like those that we need to help with to respond to the opioid crisis. He's been an innovation leader in identifying the common components of successful evidence-based practices. My colleague is a past president of the American Academy of Social Work and Social Welfare. He's been a founder of a national effort that's entitled The Grand Challenges of Social Work, Ending Homelessness, Stopping Family Violence, Ensuring Healthy Development for all of our youth. So please help me welcome Dean Barth.
Thank you, Jed. I, like many of you, have been deeply affected by the addiction of someone I love. In my case, my son James, who has been using methamphetamines for more than a decade, which also means that he lives the hard life of being homeless, despite our many efforts to help him to be housed. In the work that I'm doing with Natalie Eddington and colleagues all across the campus at the Center for Addiction Research, Education and Services, I see the opportunity to interrupt the path to addiction, homelessness, death, and many other forms of pain and suffering for individuals and families affected by substance abuse. We can do this basically by adding more science to our substance use disorder systems of care. Most of us know little about the opportunities to improve substance use disorder interventions. We know little about the different paths for disrupting addiction. Most of us don't even know what our substance use disorder system looks like because we experience it in small fragments. Most of us have heard about the health service system. We've heard about the transportation system, but this is just not so for the substance abuse system. This is in significant part because addiction treatment is delivered in an acute care model when there's a crisis, and is necessarily lacking in sufficiency, quality, and longevity. In fact, less than 11% of individuals in need of substance use treatment actually receive it in a given year. Informal networks of mutual help, family and community support systems play the most central part in helping to fill this treatment gap. But these informal networks, many of which you may have belonged to and which I have belonged to, are insufficient as the field remains science resistant and fundamentally yet unprofessionalized. Although this is changing, the addiction world, more than any other that I know, has developed out of this informal peer approach to helping those with substance use disorders. Although these ways of helping have tried to fill an important gap, as I mentioned, the field has largely moved ahead without a strong grounding in science. In short, neither acute care nor informal treatment will be sufficient for responding to this epidemic, for treating SUDS, substance use disorders, and neither of these approaches is sufficiently grounded in science. And that's what we're trying to address through the CARES initiative and more broadly at UMB. Indeed, many substance use disorder service providers have a minimal amount of education and training about SUDS beyond the experience of having been addicted and being in some current stage of recovery. Some may have a certificate, a few have a license as a clinical social worker, as a counselor, but the majority lack sufficient knowledge of evidence-based models of care to inform their work. So from a workforce standpoint, it's part of our mission to make sure that these evidence-based interventions that do exist are more broadly disseminated across the educational world. Individuals with SUDS, like individuals with other chronic diseases, should be afforded care guided not only by provider dedication and concern, but also evidence-based approaches known to improve outcomes. Although we do have nearly 50 years of science in some areas of addictions, including relapse prevention, controlled drinking, reinforcement-based treatment, and medication-assisted treatment, all of which have shown to be effective, most individuals with substance use disorders get almost none of these evidence-based practices, and if they get any of them, they get them very briefly. So the Center for Addiction Research, Education, and Services, which was established last year, is here to try to bring science to services. Whoop. This involves an approach that focuses on 4 outcome goals: access to evidence-based treatments, quality of treatments, improved outcomes, and consumer satisfaction of substance use disorder services. At UMB, we bring our combined expertise as clinicians, social workers, epidemiologists, service researchers, intervention specialists, evaluators, basic researchers, and policy analysts, to name just a few. So one of the first things that we are working on, and this is hardly complete, it's just we're starting this effort, is to lay out what the service looks like in our state and what it should come to look like. Here are 10 issues, and you have them also in your handout, that need to be considered for any substance use disordered system of care. And I don't have the time to take you through all of these, but I'll just give you a sense of what some of the evidence is and what the research needs are that we will be trying to address. So one of the clear needs is reducing the misuse of medications. And one of the pilot studies we just funded looks at how medications remain in households or are misused following palliative care, just as an example. Brief screening, brief intervention, referral to treatment. SBIRT is an intervention that's well known for being effective, and we've had training programs in medicine, nursing, social work, and in other schools at SBIRT for a long time now, and want all of our students to get trained in that way. Smoking cessation. There is inevitably a link between people who smoke and people who, and the way they respond to addiction. Reducing smoking using nicotine replacement therapy and other evidence-based practices is a critical part in addressing addiction, but we need to know a lot more about that. Access to medication-assisted treatment. If you go to the Substance Abuse and Mental Health Services Administration website, just about the only thing that you'll see on there is medication-assisted treatment as an evidence-based intervention. That means getting people to use methadone or buprenorphine, some medication that reduces the impact of the addiction, but that in and of itself is a ongoing, needs and requires ongoing use. So medication-assisted treatment, we are trying to expand that, but it's up against considerable difficulty because the tradition has been one that I'll speak about in a little bit of pushing people to abstinence and getting people away from medication use. Narcan or naloxone is the intervention that many of you have heard about. Some of you may have even used to interrupt opioid overdoses or other kinds of related overdoses, and that's something that we need to disseminate more broadly, and we have research ideas related to how to do that. Residential or inpatient detox is obviously considered to be the treatment of choice. We've all heard about the Betty Ford Center. There's inpatient and residential treatment everywhere in this country. How effective it is varies dramatically, although we don't talk about that very much. And what the follow-up is critically influential in what the outcomes of residential treatment will be. Recovery residences. There are many recovery residences in Anne Arundel County, all over the country. These are informal places where people go after they've been in the emergency room, or they've been in residential treatment, or they've been on probation, where they can go and live with their peers in what's also known as sober living. Turns out it often isn't sober living, and it can benefit from, and my colleague Michelle Tootin in the School of Social Work has a very powerful study on reinforcement-based treatment. These recovery houses, which are very informal, can benefit from structures that reinforce a whole series of steps that progress people towards employment, family reintegration, and recovery. Psychosocial supports. One of the things we're learning about medication-assisted treatment is that it often doesn't stick. People don't stay on their medication-assisted treatment. Why is that? Often because they don't have the psychosocial supports or the family supports. And then vocational and educational services. There's no question that people are more vulnerable to addiction if they aren't anchored to some educational or employment outcome. So at UMB, we're involved in understanding each of these topics that are the building blocks of a world-class system of substance use disordered care. And for each of these 10 issues, we also need to consider, as if this wasn't complicated enough, how this system takes into account the unique needs, proclivities, and sometimes biological characteristics of different subpopulations. So Michelle Tootin, for example, works with pregnant women, and they obviously have particular medical conditions that are may interact with methadone or buprenorphine. Fortunately, that doesn't seem to be, in general, as much of a risk as many people think. But for each of these groups, we need to figure out how do we get evidence-based treatments to them, and how do we help them sustain them so that their recoveries can be sustained. The success of these services are also affected by the culture of those being served. And that's something that we spend a lot of time on and are studying also at UMB. And one of the other factors is the extent to which drug users and their families understand the stigma of substance abuse. For example, are each of you could ask yourselves, are you comfortable with using medication for what may be long-term? Would you be comfortable staying on methadone or buprenorphine? Are you somewhat ashamed, would you be somewhat ashamed in wanting yourselves or family members to quit, to show the willpower to become abstinence? And what messages might you be receiving, or your family members or those you love be receiving from family members, friends, and their community about the use of medication for treating their substance use disorders? As substance use disorder scientists, we must get better at understanding how families can support the progress of their loved ones in addressing the chronic relapse and compulsing nature of disease and getting beyond the stigma. So for example, at UMB, we have a protocol that we're working on with the VA on ways that veterans and their family can reduce the stigma of behavioral health disorders. So we're working on all of this, as I wrap up, using varied tools from the analysis of big data, for example, trying to understand what kind of emergency room and 911 calls are coming in that may be related to Narcan, the need for Narcan or opioid overdoses, to qualitative interviews of drug users and dealers and their social networks, to workforce development through training and evidence-based practices, and testing ways to increase quality outcomes and consumer satisfaction. We're also trying to understand how the ordering and timing of various services matter. This, if you think about the course of people going in and out of the emergency room, you'll never be able to read this, so just think of it as an impressionistic picture of the longitudinal system of care. You will see that people are coming and going from various services without proper transition planning and without really a clear path forward for their treatment. So we believe that we have great opportunities to improve each of these interventions at each of these points in time to increase the likelihood of prevention, a shorter involvement with substance use disorder, and faster and longer lasting recovery. Which brings me back to the beginning of this talk and reminds me to thank all of you for your concern, for all you're doing as practitioners and family members, for the opportunity to address you tonight, and for any suggestions you have that will help us better understand what a world-class substance use disorder system of care would mean to you. Thank you.
Thank you, Rick. If I heard what I thought I heard, I don't think I've ever heard you try to talk over a farm animal.
I wasn't expecting that when I came to UMB.
Well, that's why we have to get out on the road, you know? Let me introduce my colleague who leads our School of Pharmacy. Dr. Natalie Eddington is Dean of our University of Maryland School of Pharmacy, nationally known expert in drug delivery and in pharmacokinetics, how medications are metabolized. Her work includes NIH-funded research examining the underlying mechanism involved in drug abuse and addiction. And under her leadership, our School of Pharmacy is approaching our nation's opioid crisis through many disciplines, from basic research to population health research. The school is involved in establishing protocols on suspected drug abuse and diversion and the appropriate use of medications known to be highly addictive. They're developing an opioid, you're going to hear about this, with no abuse liability, and training community members to safely administer naloxone. They've launched programming on addiction science and on opioid prescribing. They're collecting expired and unused drugs to prevent these issues. And they're digging into data to understand substance abuse trends throughout our state. Like my colleague Dean Barth, Dean Eddington has served in leadership positions in both pharmacy and science organizations, including her recent term as chair of the Council of Deans for the American Association of Colleges of Pharmacy. Please help me welcome Dr. Natalie Eddington.
Good evening, everyone. I think we can do better than that. Good evening, everyone.
Good evening, Natalie.
It is a pleasure to be here with you. I am so happy to see so many folks that I know, and the room is full, and that means that you are very interested in this very important topic. I have the opportunity this evening to really talk to you about our Center for Addiction Research, Education, and Service. And I'm not going to talk long because I know and I hope that you have many questions for us, and we also want to hear from you in terms of your thoughts and your concerns surrounding addiction. The Center for Addiction Research, Education, and Service is a very bold step for a university to take, and I think that we are a unique university in the sense of the constellation of schools that we have that can really have an impact on substance use disorder. So the mission of CARES, our center, is really focused on strengthening and advancing the university's efforts to address the adverse impact of addiction on individuals, on families, on communities, and society. The center has 4 areas of focus that tap into the outstanding skill sets of our faculty across each of our 6 schools. The first one is workforce training, and that's what we do at our university. We train pharmacists, lawyers, social workers, physicians, nurses, and dentists. And as part of that, one of the opportunities that we've had over the last 10 years is really to have educational approaches that really tap into the interprofessional nature of our university. And through the CARES core of workforce development, we hope to be able to do that as it relates to, first, identifying and reducing barriers to addiction-related workforce participation and retention among current and future behavioral health providers, but also looking at this interprofessional group of expertise that we have and using the Center for Disease Control guidelines to really focus on how we prescribe medications consistently as well as dispense medications. And I think we can be a role model for other professions, other universities to really implement these kinds of programs. The second core of the center is focused on developing innovative models and systems of care. And through that, we want to expand innovative models and systems to prevent substance use disorders and to improve patient access to quality substance and use disorder treatment. And with innovative models of care, as my colleague mentioned, we recently had a seed grant competition at the university to really get a better idea of the research that's ongoing, the practice activities that are ongoing, and really to identify the actual research that's ongoing. And one of the things that we learned is that there is a great deal of rich hypothesis-based research ongoing. And one of the areas that was extremely interesting in terms of innovative models of care was there was a clinic that was proposed that focused not only on substance use disorder, but looking at some of the challenges with substance use disorders in terms of other chronic diseases like HIV and hepatitis C, and ensuring that patients that have substance use disorders and chronic diseases are able to have access to care and be able to do this not having to go to one provider and another provider, but providing that care in a comprehensive manner. And so I think that those are the kinds of things that really can help in terms of the crisis that we're in and meeting the needs of patients where they are. The next core is our translational addiction research, data surveillance, and management. And this core is focused on expanding addiction-related research and data surveillance to identify and respond to patients' needs and emerging trends. And you'll hear about one of the new compounds that's being developed at the university from Dr. Coop later on. And finally, the fourth core focuses on policy analysis, development, and education. And it will provide addiction-related policy consultation, training, and analysis to local and state governments. And we are very fortunate to have a School of Law on our campus because one of the biggest issues that we see as it relates to access to care are those laws or those policies that prevent each of the professionals on our campus from working at the top of their license. And so the CARE Center and its 4 cores are really focused on providing solutions to substance use disorders and ensuring that our students are exposed to this education and these experiences, as well as tapping into all of our faculty. Thank you very much.
Thank you, Natalie. We've been alluding to this compound we're developing. So let me introduce you to our colleague, Dr. Andrew Coop, who's professor and associate dean for academic affairs at our School of Pharmacy. A little bit about my friend Andy Coop. He was awarded the Joseph Colchin Young Investigator Award from the College on Problems of Drug Dependence, which is the oldest group in the United States addressing problems of drug dependence and abuse. For 18 years now, and this is no mean feat, Dr. Coop has been funded by the National Institute on Drug Abuse, an institute of the NIH, for his work on opioids. And yes, he discovered UMB 425. Now, I did not tell him I have to call it UMB, but I'm delighted with the fact that he did that. As you'll hear, UMB 425 is an opioid painkiller with the potential for no abuse. And this incredible breakthrough has been featured in the Baltimore Sun. I'm sure you've seen some of these articles, the Washington Post, the Atlantic, and more recently, I guess, in the book Dreamland.
Yes.
So please welcome Dr. Andrew Coop.
Thank you. Thank you, Dr. Perman. And it's great that you are all out tonight. We all take addiction, and I will stop using that term very, very soon. We all take addiction very seriously because it impacts all of us. I did watch when Dr. Perman asked, put your hands up for who this has impacted, and I think everybody did. Dr. Perman mentioned in his introduction that I don't like using the word addiction. I don't, because we can't define it. And it's associated with the stigma that my colleague, Dr. Barth, mentioned. It's like saying cardiovascular disease. Well, what is that? It could be anything. We've got to get down to what the diseases are and be very precise about it, because what we're talking about is a disease. It's a disease. And that's what we need to keep mentioning. We need to keep repeating that. It can impact all, it does impact all of us. When I started my work 19 years ago, I approached this with, we need a better version of morphine. Better. How do we define that? We need everything we've talked about tonight. We need to solve the crisis we have now. But as a university, we also need to think about our children, our grandchildren, our great-grandchildren, the future. When none of us are here anymore, we don't want these people to be dealing with the same issues we're dealing with. So we have, what are we doing now? What I'm focused on is, what are we doing for the future? So this is where I started working. I want a compound that treats pain as well as morphine, but isn't addictive. So the first thing is, well, how do we do that? And Dr. Perman mentioned, I talk about two terms, and this is the two things I want you to take home from tonight. Are the two terms dependence and reinforcement. Okay. The different mechanisms that, believe it or not, I go around the country talking about these two terms, and there are many, many healthcare professionals don't know the difference. Reinforcement is when you take the drug to get high. It's reinforcing. You inject a drug, you inject heroin, you snort heroin, because it's reinforcing acutely to get high. And you do it again to get high. That's reinforcing. Now that is very, very different to dependence. Dependence is when you've taken the drug chronically for a long time. For whatever reason, you've been in hospital, you've been having surgery, you were given morphine to treat the pain. Our bodies are wonderful things. We adapt. We adapt so that morphine being there, morphine, fentanyl, any of these opioids, is now the natural state of being. Your body adapts to it being there. So what happens when you take it away? You're not natural anymore. Your body goes into withdrawal. So you seek drug, not to get high, but to prevent the withdrawal signs. If you guys have all seen the issues in the newspaper recently about overdoses of Imodium, right? People are not taking Imodium. Imodium's a very weak opioid. People are not overdosing on Imodium to get high. They're overdosing on Imodium because they're trying to alleviate those withdrawal signs. So when we're looking at a drug, we need a drug that if you give chronically doesn't cause dependence, as in when you stop, you don't get withdrawal. But we also need a drug that won't get diverted, wouldn't be reinforcing, wouldn't be high. UMB 425. I know what I'm doing calling things UMB, Dr. Perman. UMB 425 is something I've been working on for 18 years. The dependence in animals is solved. Doesn't cause dependence in animals. But I'm going to tell you the truth. It is reinforcing. We give rats the chance to inject this. They love it. So we're halfway there. This is the honest truth. Someone asked me tonight outside, are we in clinical trial? No, that would be wrong. That would be wrong. We've got the dependence solved. Well, I need you guys to support UMB and support all of us and get the word out there that we now need to solve the reinforcement. I'm working on it. That is my vision. So that in 50 years' time, we're not sat in this room having the same conversation. Thank you very much.
Okay. My colleagues have hopefully covered the waterfront, granted at a very high level, in terms of some of our research efforts, our responsibilities to educating providers, and at the same time doing what so many of you are totally devoted to, which is to serve a population with current needs. And please, I'd love for you to question us, contradict us as you see fit.
Yeah.
And give us your ideas and your partnership. So the floor is open.
Hello, testing. So my name is Kendrick Faison from Leadership Anne Arundel, but also the president of Spatial GIS. I am actually a son of both of my parents were addicts, right? But I think one of the things you said, so I'm a business owner, and I think you talked about workforce development, so I'm really big on that, especially from a veteran and a person that has an addiction. But one of the things I think from a CEO perspective, there's a stigma. How best can we introduce people into the workforce that we're not also looking at them more at a scope for a relapse or because we still have the vulnerability in regards to that.
It's a risky person to hire. That's
right,
what you're
correct,
saying.
exactly.
Well, absolutely, indeed it is. I think being as clear as possible about what the challenges are for people, trying to provide some supports for them out of your business or through an employee assistance program or by arranging other opportunities, making sure they have the time and the encouragement to go to get their treatment, to get methadone, to get bupe. All of those things are part of this. A lot of it does come down to trying to figure out how to align their family, work, and community to allow them to go forward with their treatment and not feel like they have to finish it, they have to complete it, they have to stop in order to avoid being treated harshly by those in their environment.
You know, employee assistance programs, we are of a size that we can offer that. We do at the university. We have 7,500 employees. For the small business owner, it's not so easy to say employee assistance program, so I think it's a challenge. Others?
In the Washington Post this morning, I read that Jeff Sessions is proposing that pharmaceutical companies limit the amount of opioids they produce. How does that impact the street drug life and the less regulated products?
In Eddington?
I'm looking at core 4 as...
Right. I think one of the initial reactions that you'll see if there is a decrease in the availability, the prescribing and the dispensing of opioids, and you have in your community patients that have substance use disorder, they're going to seek other medications. One of the things that I think is very important when we talk about opioids as it relates to prescribing and dispensing, the Center for Disease Control has very tight guidelines and protocols specifically on how you prescribe and how you manage pain. One of the big challenges that we see is that is not consistently practiced across nurse practitioners, physicians, pharmacists in dispensing. And so the challenge is that, or the opportunity, let's put it like this, is that there is a prescription drug monitoring program in each state except Missouri. And this program can actually in real time give you information about the prescribing habits as well as dispensing habits. But the challenge with the database is how do you use the data and how do you get the data to physicians, pharmacists, or others that could have a way to actually address that hot zone, so to speak. But back to your point, I do think that it's laudable to do that. It's important to do that. But I do think that initially, if this takes effect, that you're going to see major challenges with patients that have substance use disorders using other medications, such as heroin and fentanyl.
Less regulated.
Yeah.
Yes, yes.
Andy, do you want to comment further? No?
It's fine. I was going to say, if you've actually, the book that was mentioned by Dr. Perman in the introduction, Dreamland, if you actually read that book, it's a great book, even though I'm mentioned in it.
What's it about?
Dreamland, it's all about how black tar heroin
I hope you
took
heard
over.
the disclosure there. He's mentioned in the book.
He wrote a chapter.
I was actually interviewed for the book, Dreamland by Sam Keonis. It's a book about how black tar heroin effectively took over the Midwest. It's a wonderful book. But if you read that book, not only should we look at the pharmaceutical drugs that come in through the pharmaceutical companies, but we need to take a holistic approach for how illicit drugs are also coming into the country. And I am actually working with the DEA on that.
And there's no question that the death rate is now much more attributable to the latter than to the pharmaceutical, the misuse of pharmaceuticals.
You know, your comment, though, Lisa, forgive me for a moment. Your comment, though, reminds me as a physician who, in his own specialty, virtually never prescribes pain medication. I worry that there's a fine line here. We have to deal with the substance abuse issue, but as one of my colleague nurse practitioners in our shock trauma unit reminds me, people need pain therapy. We can't forget that. No. We can't, if you will, throw out the baby with the bathwater. So that challenge, that interface needs to be dealt with.
Yes.
Ms. Hillman.
Hi, I'm Lisa Hillman, mother of someone in long-term recovery, praise God, author and a fan of Jay Perman. So I have a different kind of question. Since you brought up Dreamland,
yes,
then you know that Sam Quinones says the antidote to heroin is not Narcan, it's community.
Yes.
So my question, and I'm excited to have a room full of scientists. I assume you all think about yourselves as you are scientists. I'm interested to ask a panel of scientists, where do you think the concept of spirituality, community, the 12th step, where that fits into the system of care that you're trying to create?
That's a good question. Rick, do you want to start?
Sure. So it's the response to something as complex as heroin addiction or opioid addiction is going to be multifaceted, and it's going to vary by individual. But in a general sense, the 12-step model doesn't do very much. There's really almost no science that suggests that if you use the 12-step model, that it would outperform for example, medication-assisted treatment approach. Would it do more than not being in a community? Would there be opportunities there for success? Sure. And I'm not saying that we should, disassemble all those many peer helping programs that are very, very positive. But on the other hand, it's not predictably a powerful intervention, and on average, it's a weak intervention. That doesn't mean that some people don't benefit, but on average, it's a weak intervention. So I think what we really need to see, and Maryland is taking steps in this way, is that, for example, sober living homes, recovery homes, which have relied on peer models, now must also offer medication-assisted treatment. They can't say, well, we just don't believe that anyone should, that everyone has to be abstinent here. No one should be allowed to use medication to improve their quality of life, and no one should be allowed to treat this as a chronic disease rather than, that needs medication treatment rather than as a sort of a social phenomenon that only needs a social intervention. So that's a big step forward, that people should be allowed to get what it is they need, and that our ideology shouldn't keep people from getting other evidence-based interventions just because there's a philosophy that says that abstinence is the only way forward. And I'm not saying you are saying that that's the philosophy, but that's what we see in a lot of recovery programs. And follow up if the man with the mic allows.
I appreciate that. I think if there were people here, and there may be, in recovery who succeeded through the 12-step programs, through AA, through that community that got them clean, that keeps them clean, I think they'd probably argue with you. And
they would.
I don't know if science can look at that and see if there is, I concur that you need evidence-based practice in almost any disease, in all diseases, but is there anything going on that could study those programs? They work with thousands and thousands of people and have for decades.
And basically what we don't know is what the bounce-off rate is. So we know that they work for thousands of people. We don't know how many millions of people have tried and not received any benefit.
Hi, I'm Libby Beatty. I represent the Alliance for Safe Online Pharmacies, a nonprofit group focused on safe medicines on the internet. And the question made me think about externality effects of limiting prescribing and access to care issues more generally. You may have seen...
We can hear you. Keep going.
Is that better?
You're doing well.
Okay. You may have seen reports from the Senate Subcommittee on Investigations and Attorney General Sessions and Commissioner Gottlieb, most recently in the last 2 weeks, calling for action against illegal online sales of opioids and synthetic products, including prescription and non-prescription other drugs of abuse. So I'm just curious how you think about that as the next wave of the epidemic in terms of access to care and potential threats for illegal access, especially outside of PDMPs, to your point, outside of standards of care, and unknown to many providers.
Anybody want to respond, Natalie?
So Are you referring to, I'm trying to better understand your question. Your concern is with these online pharmacies providing what types of medications?
Controlled substances.
Controlled substances.
Yeah, 54% of websites right now sell controlled substances without a prescription, according to NABP.
Yeah.
Right, and that's a major problem, because I think one of the challenges that we have now is how do we use the data, or how do we get access and accuracy with the data in the PDMPs, but to have something that is online, that is not going through the legal process to obtain and to prescribe drugs and to dispense drugs is a huge issue. And so that's just another feeder that really enhances a negative outcome as it relates to medication, as it relates to potential overdose. It's difficult enough to really look at prescribing and dispensing within a state, but to have that as another factor that we have to be aware of and try to prevent, it's going to be pretty difficult. Yeah.
Question here?
Hi, my name is Maren Schmidt. A milestone in the origin story of the opioid epidemic, to me, seems to be in 2001 when the FDA switched the indicated use of OxyContin from acute usage to chronic usage, and had never done any studies lasting longer than 6 weeks on whether there was a dependency problem. All the other long-acting opioids now have the same indication: chronic use, around-the-clock use, no long-term studies. In developing UMB 425, I guess it's a two-part question. In 425, how long would you like to have this study to be comfortable that you're not going to be putting out a drug that does develop dependence? And two, what do you think is the proper steps for the FDA to take with these drugs that it's already approved without foundation for long-term use like that?
Yeah, quick question.
So, in terms of 425, I am being very, very, very conservative. And this is one of the reasons why, even in terms of the dependence, it doesn't appear to be anything at the moment, months out. But I'm being very conservative. There are no guidelines, no guidances at the moment. And that is another place where UMB, we actually have a cooperative agreement with the FDA, the Center of Excellence in Regulatory Science and Innovation, where we get scientists, regulators, together, industry, together to help define those guidances so that we can get those guidances for future. So that would be a place that we would do that. In terms of me, I would actually want to test it always to Sunday. I'm not exactly sure how much, but I wouldn't want to put a drug out there that's not responsible, that potentially could make things worse. I also agree with you that one of the turning points was the change, but that wasn't the only one. There was also the Joint Commission, right, who now claim they didn't, but they did, claim that pain should be a vital sign. They claim they didn't, so we've got to be very careful if I'm being taped. But that basically ensured that all healthcare facilities assessed pain and made sure that everyone had no pain, which caused over-prescribing of opioids. At the same time, we need to make sure people are pain-free. It is a double-edged sword. But we had the Joint Commission, we had the high levels of opioids, and it all came together to cause the explosion we have.
So, colleagues, we promised a 7:30 end to this part of our opportunity to be here, so that those of you who have evening obligations, family obligations, can depart. We are going to be here till 8, so feel free to engage us in conversation, those of you who may have further questions or comments. I'll close with telling you that I am going to serve as a subject in a study that sort of caught my attention somebody in our nursing faculty is doing a study using augmented reality. I don't know how many of you have had experience with augmented reality. You put on a set of glasses and suddenly you're in the middle of something that's 360. And so the study that I'm going to be a subject in puts me on stage in an opera. The performer's on stage, I'm with them. I have no business being there, but I'm with them. The orchestra's in the pit behind me. I mean, this is the real deal. And they are going to subject me to pain. And the purpose of the study, of course, is to look at other modalities that reduce the need for medication. It's still there, but take advantage of other dimensions of therapy that will potentiate treatment. I find that sort of exciting. Watch for news. Thank you very much.